Hello, good morning. Can you hear me? All good? Okay. I'm Amanda. I'm one of the PGY4s in the program. And today for the grand rounds, we're going to talk about surgical education with a focus on CBME and surgery. Before I get started, I just wanted to extend my gratitude to Dr. Kavanaugh, who spent a lot of time, effort, and energy helping me out with these. And then also thank you to Dr. Anderson and Dr. Dillis Reyes as well, who both gave input. So just a quick overview of the presentation. I'm going to start by introducing the concept of competency-based medical education by looking at the evolution of surgical education, and then defining CBME in the context of urology. And then we're going to review the validity, positive benefits, and the areas that might be lacking due to CBME implementation. And then finally, I'm going to try to discuss novel emerging solutions to close the gaps that CBME may have opened. So in order to understand where surgical education is today, it's useful to look back at where we came from. So the concept of surgery really was established in the Middle Ages. During this time, barbers who had high dexterity would perform some minor procedures like bloodletting and dental work. They were trained under an apprenticeship model outside of hospitals, mostly within the military, and it was pretty distinct from the field of medicine. And then obviously back then there was no standardized curriculum. The quality of your skills really just depended on who you trained under. This was changed in the 1900s when William Halsted created the first modern residency system, which sort of forms the basis of how we train today. There was a strong emphasis on extremely long hours and hierarchies. And then by the 20th century, surgery had expanded significantly with accrediting bodies, formalized requirements. And then after the Second World War, there was a wave of education reform, which brought about the first of competency-based education programs. It started in teacher learning and then spread to vocational traders, corporate training, aviation engineering, and so forth. And then in the early 2000s, Ronald Hardin, who's considered the father of modern day medical education, proposed expanding this concept into medical curriculum, and that's what catalyzed the introduction of competency-based medical education. So globally, there's over 80 medical schools and postgraduate systems that have implemented CBME frameworks or some sort of CBME framework. In Canada, the Royal College's Competence by Design launched in 2017. And as of last year, all 67 specialties under the Royal College have transitioned or in the process or transitioning. Urology transitioned in 2021. And what that translates to is an estimation of over 10,000 residents who are currently training under this framework. So competency-based medical education, sort of a nebulous concept, so I think it's important to characterize what it actually is. So according to the Royal College, the official definition is that competency-based medical education is an outcomes-based approach to the design, implementation, assessment, and evaluation of a medical education program using an organized framework of competencies. In our case, it's the CAN-MEDS frameworks. A curriculum is organized around outcomes expected of a resident, and the resident's advancement is dependent on having achieved those expected outcomes. So CBME is essentially a philosophical concept that aims to shift the focus from historical time-based learning to achieving competencies required for safe and independent practice. Competence by Design is the Royal College's version of CBME. And what it does is it organizes residency training into 4 developmental stages. There's transition to discipline, which is supposed to be early residency, and then foundations of discipline, core of discipline is somewhere in the middle, and then transition to practice is where our R5s are now pretty much. And each state of training contains some predefined learning outcomes, which are termed milestones. So a few other terms from the Royal College. So milestones describes the expected ability of a healthcare professional at a certain stage of training. They're used to guide curricular development, they're used to track progress, they're used to allow staff to help you track progress. And then entrustable professional activities, or EPAs, are key tasks that a trainee resident can be trusted to perform without supervision once competence has been met. They get progressively more complex as residents go through training. And then finally, there's competence committees that review residents' progress at regular scheduled meetings over the course of their training and then determine if a resident can actually progress to the next stage. So this is sort of a busy slide, but to synthesize this and to put things in the context of urology, this is an excerpt from a document that the Royal College published in 2023 describing what our pathways to competence is in urology. So here the competency-based framework is in the collaborator domain, as defined by the CADMETS frameworks. And then the competency of working effectively with other physicians, other colleagues, it's laid across the 4 developmental stages. And then within each column are milestones that shows how this is expected to look at each stage of residency. So when you start residency, you're in R1, you're in transition to discipline. You're supposed to be able to compare and contrast enablers and barriers of collaboration in healthcare. And then at somewhere in the middle, you learn how to respect other people. And then when you're R5, you're supposed to be able to establish and maintain healthy relationships with other physicians. And then this forms the basis of generation of EPAs. So this is, no, it's not. Yeah, this is an example of an EPA. So it's collaborating with other services. And it's an EPA that drew on those linked milestones from the slide before. So given that competency-based medical education governs our knowledge acquisition, it's been around for quite some time now, and it's continuing to expand globally. I think it's important to evaluate the validity, positive outcomes, and possibly the limitations of its implementation. So this is a study that tried to address the validity of competency-based education. This was a prospective randomized controlled trial. It was published in 2011 from the Mayo Clinic, and it aimed to evaluate a competency-based, simulation-based curriculum for laparoscopic inguinal hernia repair. So what they did was they took 50 residents, 50 general surgery residents from PGY 1 to 5. They got them to perform baseline MIS inguinal hernia repairs in the OR. And then these residents were randomized to either traditional time-based learning or a mastery-based learning. The traditional time-based learning was essentially having the residents continue regular clinical practice. There's no formalized learning curriculum. But then mastery-based learning is essentially having the residents go through some modules, and then they trained on a hernia repair simulation system. And then there was faculty there giving immediate feedback. And then essentially you train until you get expert performance. And that was defined as getting 2 hernia repairs done in a certain amount of time. And then if you were not able to achieve that competency, you just came back and returned training until you were able to achieve that. And then the outcomes that they looked at was operative time, performance, and patient outcomes. So they did 219 repairs on 146 patients. And what that demonstrated was that the residents who trained under this mastery-based training curriculum were significantly faster. They had better operative performance scores. There was also a decreased frequency of intra-op complications and post-op complications. And the patients also had a shorter length of stay and didn't really require an overnight hospital stay if they were trained by residents who went through this competency-based medical education curriculum. So this suggests that there is a benefit towards a sort of competency-based, simulation-based training regime for surgery at least. Similarly, this was another paper that attempted to look at the effects and outcomes of CBME. So this was a paper that was published last year from JAMA, and it was trying to evaluate an association of milestone ratings in newly graduated vascular surgery residents um, with subsequent complication rates following endoscopic aortic aneurysm repair. And so they looked at around 4,000 of these procedures from 800 vascular surgeons. And all of these graduates completed training between 2015 and 2019. And they graduated from an accredited training program from the United States. And they all had milestone ratings within 6 months prior to graduation. And then what they found was that after adjusting for patient risk factors and the site of training, there was a significant association that was identified between individual milestone ratings of surgical trainees and major complications in early surgical practice. They did find, interestingly, that for surgeons who graduated from programs with lower mean milestone ratings, that association was much weaker. And this is the first and pretty much the only study that details the association of competency-based milestone during training with patient outcomes following training. When it comes to official data from the Royal College itself, there is a CBD program evaluations operations team that conducts national studies to evaluate either one of the three, either readiness of a program to implement CBD, a program's fidelity of implementation, and then also the impact of CBD over time. And so far, there's been only 2 peer-reviewed national studies officially published by the Royal College. They were both published in 2022, and then they looked at the readiness of programs to implement CBD and then adherence to CBD principles. The first one sort of addressed the readiness of programs to implement CBD, reported high journal capacity and overall motivation towards implementing CBD, but they noticed that both trended downwards between 2019 and 2022. The second paper addressed the fidelity of programs to CBD principles and reported that overall implementation of features were progressing well in programs, and competence committees were the most fully implemented, but coaching over time, coaching in the moment, or giving feedback essentially was the least fully implemented features between 2019 and 2022. So probably a bit more useful is these resident physician pulse checks that the Royal College has put out. These are essentially national resident surveys on sentiments on CBD, and it sort of helps us delineate the outcomes and impacts of competence by design. The most recent one was published in 2023, and they had responses from about 800 residents and all 13 participating institutions from 47 disciplines actually responded. So the biggest perceived benefits that were reported by residents was that of structure. So residents reported that they most often credit competence-based design with structure. So they had a formal feedback mechanism. There was clarity of expectations, and then there was progress tracking, that residents most appreciated. So competency-based medical education is a conceptually sound framework that's well implemented, well adhered to across the nation. And there's emerging evidence of its palpable benefits. But there is sort of a dissonance in how it's actually been received. So in the 2023 resident pulse check, the greatest challenges reported by residents were concerns about the validity of CBME. And so they were concerned about whether EPAs were really reflective of competence. And as such, is it really worth the extra work? They also felt that there was additional time taken for documentation, and there was a lot more paperwork and a lot of administrative burden, and that was a significant challenge as well. And then residents also noted that despite there being an improved system for feedback, actually obtaining quality feedback was quite a challenge. And then, surprisingly, 77% of residents indicated that the transition to CBD negatively impacted their wellness. In the 2021 Pulse Check, it established that having high administrative workloads associated with EPA completion, concerns with EPAs itself, as in being able to complete the EPAs and the questions regarding the validity and value of EPAs, and also having inadequate feedback were all cited as contributors to poor health and wellness. So these concerns are also prevalent within urology. So this was a national survey that was published earlier this year. It was examining learner and faculty experiences with CBME 5 years post-implementation. So they sent out 2 online surveys and distributed this to Canadian Urology resident program directors, faculty, and senior residents. They surveyed 33 senior residents and 29 faculty members or program directors. And overall, they found that 69% of respondents were unsatisfied with competency-based medical education. Only about 11% were satisfied with this implementation. Anxiety and fatigue were reported in not only urology residents, but in faculty as well. The increased workload, the administrative burden, and assessment fatigue were expressed by 66% of faculty. And both faculty and residents noted there is an increase in quantity of feedback, but not in the quality of feedback. There is also a general consensus on the validity of CBME framework, with over 50% of people feeling that CBME has really not de-emphasized time-based learning, and it hasn't individualized progression, and hasn't just succeeded in general. So while there are definitely benefits to the CBME framework, there are also reported limitations as well. And if we take a list of all of those highest reported concerns in all of those previous slides, you can actually group them quite broadly into 3 main themes. It's validity, administrative burden, and feedback quality. So primarily, there's the question as to whether CBME is valid in itself and actually improve patient outcomes. The second concern was a major time and admin burden due to the increased number of assessments. And then despite the increased number of assessments, the quality of feedback has not really improved. So the concerns raised in the literature around validity question whether competence can actually be discretely defined or assessed. And they highlight there's a potential mismatch between abstract competencies and real-life clinical practice. There's also questions on whether current assessment tools really capture competence or if they truly align with clinical reality. And then there's also questions about rater inconsistency and subjectivity. And the thought is that both of those components are just part of complex interpretive validity and not necessarily errors. And then lastly, consequential validity is not really applied currently. So people who are not really meeting competencies are not fired from becoming doctors, and we're not really risking our workforce by graduating people earlier, like years earlier, if competencies are met earlier. And then high administrative burden and feedback sort of go together because the increase in quantity is sort of a trade-off for decrease in quality of the feedback. So assessments in our framework right now kind of look at whether there's competence or not on a particular skill or an EPA, and whether someone needs supervision or not. And in surgical education, this type of sort of binary feedback is not necessarily helpful, only really adds to the administrative burden. Um, Granular feedback on specific areas or components of a surgery to really improve on technicality is more beneficial to learning than rather like a yes or a no, you're competent or not. So just to go over some sort of emerging solutions to address some of these limitations, just because AI, machine learning is sort of a popular topic, just to include this briefly. In the future, AI might actually be a useful addition to complement competency-based medical education and address some of its limitations or concerns. So there are some groups that have demonstrated that virtual reality platforms are able to generate kinematic or event data, and then machine learning can use this to classify expertise and surface the metrics that actually matter, which can actually ultimately set the benchmarks or milestones for learning. AI has also been found to analyze an individual's motion data and identify gaps and provide tailored feedback. And there's some groups have created sort of a virtual intraoperative learning assistant that's able to actually provide real-time feedback based on the incongruencies in your physical motions compared to experts. And this has also been demonstrated intraoperatively in the field of robotic prostatectomies, where people have taken robot telemetry and created models that relate to surgeon motion patterns to perioperative outcomes, such as hospital length of stay, Foley catheter duration, and early urinary incontinence. And these motion patterns sort of form the benchmarks or milestones for learning that can be delivered at targeted in training. So there's still a lot of work to be done on this front, but AI might be a means to refine and complete competency-based surgical education. In terms of more palpable and relevant ways that we could try to improve, an area to focus on is feedback, given its importance to it. So there's been a bunch of studies. This in particular was a retrospective review, conceptual synthesis that integrated 4 decades of data on mastery learning across different health professions. And what it concluded was that feedback is one of the strongest influences on learning and student achievements. Feedback is also believed to be the driver of progression in the framework of CBM. And feedback is also the key that transforms repetition into deliberate practice. So these are some principles of good feedback, where they're quite well known and based on landmark studies in the 1990s on feedback intervention theory and feedback models that were developed in the early 2000s. One of the hallmarks of CBM is improved feedback, transitioning teaching into a longitudinal coaching process. However, these principles are often directly traversed in traditional surgical education and hasn't really been reported to have improved after the implementation of CBME. So this is sort of an example of an EPA that we currently have implemented. So it's a form on Entrada, and there's checklists of milestones that you're supposed to have achieved or that's in progress and what's not observed. And at the very end, there is a part that says whether the faculty or staff had to be there, and that's a marker of whether you're competent or not. And at the very end, there is a section that allows you to provide some sort of formative feedback or subjective feedback. And a lot of times, because of the increased number of EPAs and the burden of assessments, there's not really not much feedback that's put into there. So, example of some of the feedback that I got. So what we've been trying to do, something that Dr. Kavanaugh has been working on with some other staff internally. It's in its development phase so far, but the idea is to generate a 30-second template feedback form done on Google Forms. You get a link from the resident prior to the case. And the idea is that after the case, you can take 30 seconds to really complete this resident evaluation. And the goal of this is to provide timely, specific feedback, technical parts of the case. So it's been started with transplant. Um, it's a form that is 8 questions based on a Likert scale score from 1 to 10. And the idea is that you break the case down into smaller components and the resident is provided feedback on each component. Don't know if I can open this.
Your presentation.
Oh, yeah. Uh, wait. So this is an example of the transplant rubric that Dr. Kavanaugh made and kind of went through with some of the transplant surgeons. So it divides the entire procedure into a few components. So, for example, there's opening, going through like skin and the abdominal layers, and then ideally provide feedback on the resident based on a scale of 1 to 10 how well they completed that part. And then going through sort of other parts of the surgery, like getting your inferior epigastrix, mobilizing the peritoneum and the bladder, and then skeletonizing your vessels, and then doing your actual anastomosis, your artery, your vein, and your ureter. And then finally closing. And at the end, there's room to take a look at some formative feedback and describe what actually went well or not. And that was pretty much the end of the talk. So sort of in summary, we kind of went through the definition of CBME, and then we talked about some of the potential benefits and maybe negative consequences or limitations that are implemented as a result of CBME. And then we tried to provide some sort of emerging solutions, including AI or more practical solutions to address the gaps in CBME.